Good morning or afternoon, everyone, and welcome to today's webinar. This webinar is brought to you by the Sub-Saharan Africa Congenital Anomalies Network, SSCAN, and the Global Health Network, TJHN, of the University of Oxford. The topic of today's webinar is congenital heart defects in sub-Saharan African countries. My name is Dr. Caroline Osoro, and I'm standing in for Dr. Leke Amin Keng, who's the co-founder, Health Research Foundation in Cameroon. Congenital heart defects constitute almost a third of all congenital anomalies. Despite the challenge of underdiagnosis, sub-Saharan Africa has the highest birth prevalence of congenital heart defects in the world, and low and middle income countries contribute about 77% of all global deaths due to congenital heart disease. Advances in pediatric cardiology and cardiac surgery, including the introduction of pulse oximetry for congenital heart defects screening and echocardiography for accurate diagnosis, have increased the survival rate of children with congenital heart disease by 95%. Unfortunately, such services are often lacking or prohibitively expensive in Africa, where the majority of affected children, over 90%, do not receive the appropriate care. The lack of diagnostic capacity results in high rates of missed and late congenital heart disease diagnosis, further limiting survival. In this webinar, we discuss the challenges of congenital heart defects in sub-Saharan Africa and present recent prevalence, experience, and best practice from the region, including the value of congenital heart disease screening with pulse oximetry in low-resource primary care settings. Before we begin, we'll run through some housekeeping. Firstly, this session is being recorded. The recording will be shared in the coming days on the Global Health Network platform, so you can review the materials and share. These materials can be found using the link that's just being shared in the chat box right now. To interact with the panel, please use the Q&A chat function, which you can find in your toolbar. If you have technical issues, please let us know in the chat, and the Global Health Network team will aim to assist you. If you'd like to ask a question verbally, please raise your hand during the Q&A, but we encourage you to use the Q&A box. We have dedicated time allocated for Q&A, so we'll try to get through as many questions as possible. But if we do not have time for all of your questions, we will save them and try to share the written responses along with the recording. We will now begin with the program of today. Firstly, I'd like to welcome our first speaker, who's Dr. Baba Hassan. He is a professor of cardiology at the Division of Cardiothoracic Sciences at the Sindh Institute of Urology and Transplantation in Pakistan. Baba has an undergraduate from the Aga Khan University in Karachi, Pakistan. He did his pediatric residency from the Riley Hospital for Children in the United States, followed by a fellowship in general pediatric cardiology, advanced imaging, and interventional cardiology from Boston Children's Hospital at Harvard Medical School. His research interests are congenital heart defect care delivery in low resource settings, quality improvement, specifically creating congenital cardiac cath databases for low to middle income countries, and use of artificial intelligence for task sharing, pulmonary hypertension in low resource setting, and thalassemia cardiomyopathy. He is currently the chair and professor at the Division of Cardiothoracic Sciences of the Sindh Institute of Urology and Transplantation in Karachi, Pakistan. Welcome, Dr. Baba. Feel free to start your presentation now.
Thank you very much, Caroline, for that amazing introduction. And I would like to thank the organizers and especially the network and the Sub-Saharan Network for giving me this opportunity to present. It's truly an honor to be here. So what I'm going to do over the next 20 minutes, and let me just put my timer on because I had promised Caroline that I will stick to my time, is to basically share some of the experiences that we have had within our country and also other countries which share similar kind of backgrounds as that of many countries within the continent of Africa. And then kind of using those experiences show that what is our approach to congenital heart disease. So I don't have any disclosures, no financial associations. Over the next 20 minutes, what I'll be doing is to basically first mention is that are my experiences really truly relevant to the context, to the context within Africa. Are our contexts comparable? Me sitting in Karachi, Pakistan, is it comparable to somebody sitting in Kenya, Cameroon, Uganda? And then I'll talk about a proposed approach to congenital heart disease, some innovative solutions that we have adopted, especially in the whole realm of screening for congenital heart disease that can be scaled using some artificial intelligence models. And then kind of talk about population-based integrative approach to congenital heart disease. And is it a possibility, or is it just a theoretical point that I'm trying to make? And I'll show some examples of such successful programs within low to middle income country. And then what's the way forward? So this is my journey over the over the past 20 years of my career. And I just wanted to kind of share that just to show, you know, I started off in Pakistan, did my med school in Pakistan, as Caroline just mentioned, went to the US, did my residency at Riley Children's in Indiana, then went to Boston, did my pediatric general cardiology, advanced imaging intervention. And then in 2011, I returned back to Pakistan and started working for a private institution. And I worked at the private institution for 10 years, trying to develop a congenital heart disease program. And to some levels, it was successful. But it was kind of also an introspective 10 years for me, because it kind of told me that in order to really make an impact at a much larger level and to really deal with the kind of burden of diseases that we deal with, it's not possible sitting in a private institution. One has to work in the public sector. And that's where my move and my team's move came in last year, that we have gone to a public sector hospital. And this is known as the Institute of Urology and Transplantation. It's a public-private partnership. There's no cash counter, basically. I'm sorry about that typo there. There's close liaison between the public sector and the government. There are satellite centers. It's a tertiary care surgical specialty hospital with deep roots within the communities. It has a high volume center receiving complex patients, reflective of what we see in the community. So all of these things is what made us move into this whole hospital, just because that's where we saw our work being scaled and really reaching the population. So how is my experience relevant to what you will see in Africa? Is because what we call the global north, global south, they are different terms: low to middle income country, developing, third world, one of my least favorite terms, and now the global south. And then there is the global north, which is the high-income countries. And at times, many of the recommendations or many of the solutions that are applicable in the high-income countries may not be applicable to our part of the world. And so I very strongly believe that apart from, there is definitely a value in the high income and low middle income country collaboration, but there is a huge amount of potential and value in the South-South collaboration. And I think the experiences that one has gained within many programs within the South can be applicable to evolving programs within the continent of Africa. So how is our context similar? You know, so we have limited resource, and this is the balance of diseases in low to middle income country. You have a huge burden of disease, and that burden of disease is not just the number of patients presenting, but also the complexity of patients coming to us, and also the resources that are limited. And so the solutions that comes out to address this kind of imbalance of disease in the low middle income countries, like frugal innovations, contextual solutions, solutions around population control, prevention of disease, early detection and referral, so that to improve access and decrease the complexity of disease, are very much scalable within similar kind of context and similar kind of resource limited environments. Why congenital heart disease is important for the low income country to deal with? Well, because kind of conventionally, we are thought about as countries that are only dealing with diarrhea, pneumonia, malaria, tuberculosis. Well, that is absolutely there. But look at this: congenital heart disease in 2019 within the Global Disease Burden Survey has now ranked as 4th major cause of mortality for infants in the low to middle income countries. And in fact, if you go to the high to middle income countries, the middle income again falls into that category. You know, it's the topmost cause of mortality within infants or kids less than 1 year of age. Now you can very well imagine that dealing with some of the communicable disease is not, again, I'm not downplaying that. I'm just saying it's relatively easier compared to dealing with a very complex surgical specialty like congenital heart disease. So one cannot kind of wake up at the last hour to start developing a congenital heart disease program, because in order to produce a high quality program, one has to really invest for several, in fact, a whole decade to really get to that. And so congenital heart disease is very much a disease of low to middle income countries. You can look at these figures, 96% of death because of congenital heart disease happens in low to middle income countries, 70% deaths, but in infants. And so, majority of the congenital heart disease patients in the world do not have access to surgical care. So I think solutions coming from the South have to scale. They have to scale, and one has to globally address the issue of congenital heart disease. So what is the context? Again, on the left-hand side, you can see a child prenatally diagnosed, born in a high-income setting, comes to surgery at the right time, and then goes back to a decent household where he's taken care, where he or she is taken care of, versus our context. The right hand side, you can see a child, similar disease presenting, say, like this is a child who's 1 year old, transposition, infected, malnourished. And now you have to deal with this complex disease presenting late, and then they go into a context which is very, very different, remote access to care or any kind of basic facility even. Adult congenital heart disease, unrepaired adult congenital heart disease is very much a reality of our country. And these adult congenital heart disease patients present with severe comorbidities. They have brain abscesses, they have polycythemia, they have pulmonary hypertension, infection, and all of these things. And then our infrastructures are very different to deal with these. So not only are they presenting late, they are presenting with a lot of complications, but they are also now presenting into a healthcare facility which is completely inundated. And the kind of skill set sometimes we have is also limited. So, and this is the first health interface of these patients. These patients will present to community health centers, and many times they are actually taken care of by healthcare professionals who are primary healthcare facilitators. They are, in Pakistan, for example, they are 5th or 6th grade passed women who are giving or providing this kind of healthcare, and they're exceptionally doing great. But it's predominantly a screening modality, and when you talk about complex diseases like congenital heart disease, it becomes a very tricky situation. How does one deal with them at the basic health units? So this is kind of Pakistan comparing it to the US. You can see that Pakistan has 4 or 5 major congenital heart disease centers, and when I talk about major, I'll talk about those level 4 and 5, which we have described in our paper, which can cater to complex diseases, especially neonatal congenital heart disease. Because when you talk about neonatal screening, remember that you will be picking critical congenital heart disease, and those critical congenital heart disease patients then require a place to go and get operated, and neonatal cardiac surgery is not an easy thing to do. So in Pakistan, you can easily see with the population, we have 60,000 kids born with congenital heart disease on a yearly basis, and we have very few centers to take care of it. This is data from the International Quality Improvement Cardiac Cath Registry. It's still unpublished, but it basically shows the kind of money that one has to have even a basic diagnostic cath, $1,500. And for a country like Pakistan, where per capita income is close to like $1,500 to $2,000 a year, you can imagine just to do a diagnostic cath on somebody in that, you will put the whole family into a poverty trap. And if the healthcare supportive systems are not that robust in that country, what happens is that patients are paying out of pocket, and when they pay out of pocket, what happens is that they borrow money, they get into debts, and that puts the whole family, even the children within that family who otherwise are healthy, they put them into a poverty trap. So there is a huge implication to this kind of a complexity, and doing it in a private sector especially, it becomes very, very difficult. And then when you look at what I call the healthcare influencers in our country, in our part of the world, the healthcare influencers have a different donation focus. Majority of healthcare research is funded through external funding in our part of the world, and majority of those healthcare funders have different focuses. And just look at this 2021 data. Majority of the neglected disease donation went for HIV, tuberculosis, malaria, and other communicable diseases. So, the healthcare funder has a different focus. So what we are now proposing is that we are proposing a kind of a holistic, integrative, and a population-based approach to congenital heart disease. Again, I'm going to say we cannot advocate for congenital heart disease in isolation. Advocate for it with all the other stuff that that is around, that a neonatal screen can pick. A neonatal screen can pick an at-risk neonate, which has complex pneumonia, which has complex sepsis, which has birth defect, and then develop a care pathway around it. And I think that integrative population-based approach to congenital heart disease is what is probably the solution. Children's Heart Link, which is an organization out of Minnesota, has done a great amount of work in developing this kind of a population health model, and I'll show some of their work that they've done. And so what's the traditional approach to congenital heart disease in our part of the world? The traditional approach is that pediatric care is a kind of an offshoot of adult cardiac centers. Many times it's either government or hospital-based, motivated by charity or profit. It's championed by some overseas trained surgeons or cardiologists, and it treats as many as possible whenever and however they arrive. And again, many times there is a huge amount of cost that goes into it. That again, as I've demonstrated, it puts patients and families at risk of going into a poverty trap, and also creates an unsustainable model. So what's the population health approach to this? It basically, the fourth thing that it targets is that have generalized screening, have an organized referral system, have the concept or at least the vision of universal treatment of these kids, and then ongoing follow-up of these patients. So under the umbrella of the global initiative of child surgery, and using some of their previously published documents, the cardiac surgery working group also produced a kind of a recommendation for congenital heart disease, a framework for pediatric and congenital heart disease in low to middle countries. This was recently published in the BMJ Global Health. And what have we proposed is basically a tier-based approach to congenital heart disease. Level 1 is where predominantly the screening of congenital heart disease is happening. But again, it ties into a level 2, it ties into a level 3, because again, if you just screen somebody, diagnose somebody without creating that care pathway or care continuum pathway, it's not going to benefit. In fact, at times, the community will lose interest, will actually will lose interest within that health system, which is not actually providing care then. So just screening is not the solution. So based on the age and complexity of disease, availability of anesthesia, human resource, required skills, and equipment and supplies, and also quality and safety, we have built all of these at different levels. So at level 1, as I mentioned, it's a community health center, and it basically does a lot of basically the focus there will be screening of the cardiac disease using either pulse oximeter. And the way we integrated and included other things is that not only are these patients being screened for congenital heart disease, but we also put in, for example, measurement of blood pressure, so that you start screening for non-communicable diseases like hypertension within that household or that child or whatever. And then the focus of that center will be to refer those patients to the higher centers. So it's not just screening and diagnosing, but actually really putting them onto the care pathway and care continuum pathway. So if the center number 1 was focusing tremendously on screening, and I just saw that there are some talks around pulse oximeter. So I just wanted to share some of the work that we have done around using what we call a sequential ML model, in which we built in the WHO signs and symptoms, the pulse oximeter, and then a clinical machine learning model to really improve the sensitivity and the specificity of this tool. And some of these solutions are something that can be scaled to even parts of Africa where screening is going to be at the first level, the requirement. Some of the work that we are doing, again, just to demonstrate the inclusiveness and the integrative approach, is that we kind of piggybacked onto doing birth defect surveillances within the community, and then creating a care pathway. And what we are trying to demonstrate is that if you do that for a community, actually the vaccine uptake in that community improves, because again, the community starts looking at you as somebody who are coming in to solve their problems and not just driving their own agenda. So the second level in our kind of care pathway is where we introduced diagnostic cardiology or diagnostic imaging, and then some superficial wound care also at that time. And then if somebody has been detected to have a PDA dependent lesion, to start the prostaglandins and then kind of refer these patients over. And very aptly, it has been shown the effectiveness of using handheld echo in fact, Africa has been shown by Andrea Beaton's group to detect rheumatic heart disease. This is work done using lady health workers who were using handheld echo devices and stuff. So this is something that can definitely be put into a level 2 hospital, and diagnostic imaging can be there. Level 3 is where you then start having some emergent cardiac cath procedures being done, pericardiocentesis, for example, a temporary pacemaker being placed, and a slightly more complex wound management. And in fact, you can actually start building even rheumatic heart disease, secondary prophylactic injections, and even warfarin care for those who have had valve replacement at this level of care. Level 4 is where you start then putting in cardiac surgeries, but again, kind of simpler surgeries, not very complex surgeries at that point. But you start putting that in. And at level 5, you basically have like kind of a national cardiac center or national hospital, national children's, where you are now dealing with all the complexity of congenital heart. But again, these 5 levels are not disconnected. They are all connected together. And that's how we have to think about delivering congenital heart disease, not in silos, not in isolation, but connected to each other in an integrative, and also addressing other issues. So we also then built in this whole idea that access without quality will actually cause more harm than benefit. So one has to have the quality lens when providing access. So at every level, we have actually also built in, and this is in our paper, quality metrics that can be put in place so that one can look at the quality of care provided at each level of care within that whole care continuum. So one of the ways that in which we and our program has done is to join collaboratives, the International Quality Improvement Collaborative, which is a free collaborative where surgery and cath cases are tracked. They are benchmarked to other low middle income countries, and a lot of quality improvement initiatives are taken through webinars and teaching modalities that one can adopt to improve quality. So quality is not a privilege, it's a right of a human. And whenever we are doing complex care, we have to build quality in, and that's one of the major highlights of what we recommended in our paper. So is this all theoretical? It's not, because what you see basically is this is an amazing work done by the Children's Heart Link in collaboration with the government of Kerala and also hospitals within Malaysia to actually put this whole population health approach to congenital heart disease in place. And again, it goes in with a lot of planning. What I'm trying to, this is a busy slide, I'm not going to go through this, but what I'm trying to say is that it goes through planning, and every step of this whole population healthcare approach is planned out, and when it's planned out, the work from India, that not only did they show an improvement in congenital heart disease and all-cause death for kids who are less than 5 years of age. So developing this kind of an integrative approach, population-based approach, improves outcomes for not just congenital heart disease kids, but kids with other complex diseases like complex pneumonia, complex sepsis, and all of that can also improve. So in conclusion, and the way forward, the first and the foremost is a commitment towards setting our own health priorities. This is our backyard, and we have to set set our own health priority. We start looking for collaborations that are sustainable and that are tailored towards really scaling and sustaining these efforts. Meticulous planning tailored to the context. Be inclusive, integrative, and address the complex care continuum. Not just focus on congenital heart disease, but address all the complex things along with it, because that's how you will be able to, for a lack of a better word, sell your or advocate for your agenda. Access without quality is detrimental. That is important. Please, if you are providing access, you have to put quality metrics in place to actually provide good quality care for congenital heart disease, and reach out to similar successful programs and develop those South-South collaborations along with the North-South collaboration. But the South-South collaborations, that development has to happen for us to really move this needle forward. Thank you very much, and thank you for your attention.
Thank you so much, Dr. Baba Hassan from Pakistan, who was presenting on the framework for congenital heart defect services in Africa. And the reason we invited Baba is because he's from a fellow low and middle income country. And I believe as Africans, Sub-Saharan country Africans, we have things we could learn from Pakistan as well. Thank you, Baba, for that very concise presentation. And I'm sure it's about to evoke a lot of sentiment, and a lot of questions will follow this. But I'll urge you all to hold on to your questions until we get to the Q&A part of this session, which will be at the end. Or if you cannot hold, you can put them in the Q&A box as well. I'm happy to see that we are joined by quite a number of people, including presenters and attendees from previous SSCAN webinars, and new attendees. You're all welcome. Please feel free and feel at home, as we say in Africa. In case you're wondering, I am not Leke Aminike. My name is Caroline Osoro. I'm stepping in for Leke, who unfortunately could not make it today, so I'm chairing on his behalf. And just to mention a few things that Baba has talked about, 96% of deaths in low and middle income countries due to congenital heart defects in children. That was really something that stuck with me. He mentioned us having an integrative approach in dealing with these congenital heart defects. And of course, that model that he has elaborated well, that is published in the BMJ Global Health Journal. And the thing that struck me the most is that access without quality will cause harm, is detrimental. So I'm sure that we will discuss a lot of that later on today. So we'll swiftly move on to our next speaker. And unfortunately, Professor Christine Yuko-Joey could not join us this afternoon, this morning, wherever you are. So we'll move on to our third speaker, who will give practical examples on how screening is happening this time around in Kenya. And the third, and this speaker, sorry, is Kennedy Maube, who's a clinician and study coordinator at the Kenya Medical Research Institute. He's a pediatric clinician and sonographer. As a study coordinator for the Malaria in Mothers and Babies study in Kenya, Ken ensures all newborn babies are examined and screened for congenital anomalies, including screening for congenital heart defects. His experience includes general clinical management, pediatric management, and obstetric ultrasound. Kennedy holds a higher diploma in pediatrics from the Kenya Medical Training College, a diploma in clinical medicine and surgery, and currently is enrolled for a Bachelor of Science in Community Health and Development at the Jaramogi Oginga Odinga University of Science and Technology. So please feel free, Ken. He will present on screening for congenital heart defects in newborns and infants in Kenya. Go ahead, Ken.
Thank you, Dr. Caro. Thank you so much for that great introduction. I also like to thank the team for the organizing team for giving us this opportunity for us to present our experience to you. Thank you so much. Now, what we are doing in Kenya, we are screening congenital heart defects in newborns and infants up to the age of 12 months. And the background of this basically came from the WHO. We understand that recently WHO recommended use of AL for the use of treatment for first-line treatment as a use of treatment for malaria, first-line treatment for uncomplicated malaria pregnancy. That is in first trimester. Before that, AL was used as a substitute whenever the next available drug is not available, and that was quinine initially. recently WHO updated its treatment guidelines for use of for uncomplicated malaria, where it is recommended AL as a first-line treatment for uncomplicated malaria in pregnancy, and that is first trimester. And before that, AL and other ACTs were only used for general population to treat malaria, that's uncomplicated malaria, and second and third trimester. But because of the previous observational studies which showed a promising result in AL, right now AL has been recommended for use in first line treatment for malaria in first trimester. So besides that, other ACTs, the artemisinin combination derivatives have not been recommended in use in pregnancy, and more so first trimester. This is because of the insufficient evidence that may not make them be recommended for routine use in pregnancy, and more so in the first trimester. And because of this, more data is needed on the safety of the other ACTs to be used in treatment for malaria, and more so in the first trimester. So in this concept, that's where now the MIMBA study comes in.
Ken, are you still having challenges? I could help you also share from this end if it's okay.
Yeah, kindly help me share from that end. I'm not able to scroll down further.
All right, no problem. Just a moment. Okay, if you stop sharing, kindly stop sharing, and then I will share from my end. Are you able to see it now?
Yes, I'm able to see it now.
Okay.
Yeah, there we are. Sorry for that hitch. This is the reason why you are living in the low resource setting. Sometimes you have a challenge in technology and internet. Sorry for that. Now, based on the WHO now, that's where the MIMBA now comes in, and it's a pregnancy registry study, which is a multi-country study, and it's an observational study. The main aim of it is to generate a robust evidence on the safety use of antimalarials to be used in pregnancy, and particularly in the first trimester. Now, what you're doing, we're recruiting women of childbearing age and follow them up during their pregnancy period. And during that pregnancy period, we do collect data on the range of antimalarial that they've been using during that time. Then by the end of it, we assess the outcome of that pregnancy. So our primary objective is to determine and compare the incidence of spontaneous pregnancy loss and to measure congenital anomalies, including congenital heart defects, between pregnancies that have been exposed in first trimester to quinine and pregnancies that have been exposed to other ACTs. I think the common ACTs are the AL, and we also have the artemisinin prevalence. The previous studies did not systematically screen for congenital heart defects, but now for us, we do screen for the congenital heart defects. Next slide. Now, congenital anomaly screening. Basically, what we do when you have an outcome of a congenital anomaly, these cases are systematically evaluated by trained MOH nurses who are the primary caregivers. And here we use two methods to assess for anomalies. One of the methods is by physical examination for visible anomalies, and another one is by use of pulse oximetry to screen for congenital heart defects. This is done majorly at newborn, when the baby is born. That's at maternity, within 24 hours before the mother and the baby are discharged at home. And at 6 weeks again, when they do come back for their immunization. We have some cases that these babies either are born at home and others may be delivered outside the study settings. For those cases, we do usually examine them when we meet them at the initial contact with them within a period of 1 year. So when we go to congenital heart, when we go to congenital heart defect screening, majorly we do use the pulse oximetry. And by pulse oximetry, we majorly check on the oxygen saturation concentration on the extremities, on both upper limbs, on both upper and lower limbs. In this way, we based on concentration of more than 95%. If a saturation is less than 95%, we term that case as has an abnormal SpO2, and will be prompted to evaluate this baby further for other clinical features. So depending on the age of the baby, most of the for the neonates, mostly we do assess and evaluate for signs of cyanosis, respiratory distress, or signs of a cardiac murmur. And for early infants, again, we do check for cyanosis, failure to thrive, or head diaphoresis. And all infants, apart from abnormal saturation or oxygen saturation deficit, majorly again we check for cyanosis, signs of cardiac murmur, respiratory distress, and head diaphoresis. So as the screening, our screening flow is it's mostly most of the screening bit is being done by our team from the Ministry of Health. That's the nurses and are trained in both newborn examination and screening for congenital heart anomalies, and it's done from point of delivery and as well as when they do come back for the mother and child care unit. So they are screened by the MOH nurses. Then the cases that are turned positive for congenital anomaly or for congenital heart defect, these cases are subjected to further evaluation by the study clinicians. Now, study clinicians will again screen these babies, and the ones that who are screened positive. Now, those cases are the ones now we do take them for initial echocardiography. And this echo is usually done by the local technician. Now, the local technician, based on this report, for the cases that are now turned positive or screened positive for congenital heart defect, now those cases now we do take them off to a pediatric cardiologist for confirmation. Yes, Carol.
Yeah, yes. Seems like I'm the one now who's stuck. Just a moment. Oops, sorry. That okay?
Yeah, it's okay. Sorry. So what we normally do for our pointer for us to start suspecting maybe a child has a congenital heart defect, it's by use of pulse oximetry, and the algorithm that we use majorly is by use of oxygen saturation concentration. So we do take pulse oximetry on the right upper and lower limb of the babies. So whenever a saturation is less than 95% in either limb or less than 2% difference, that baby will be subjected to the initial assessment. And that initial assessment basically does a further clinical examination to observe any other abnormalities such as cyanosis and cardiac murmur. So for instance, suppose we get any abnormal feature, that baby will be referred directly for echocardiography. Suppose it's turned positive for congenital heart defect, now it will be referred for another specialist. But at times we have some cases where the saturation is abnormal, but the initial assessment when we do a clinical exam, the baby is normal. For those cases, we do repeat SpO2 at least after 2 hours from the time you did the initial SpO2. So for those cases, again, once you do repeat SpO2, if the concentration again is abnormal, greater than 95%, that baby we do refer them directly to for echocardiography. But for the cases where repeat SpO2 and the saturation is normal, that baby, those babies we normally refer them for their normal either neonatal or infant care. Again, we have babies who, when we do initial pulse oximetry, saturation is always normal at initial points. For those cases, we do not go further to evaluate them, but what we do, we usually refer them for further normal care, either at the neonatal wing or the infant care. So so far, the preliminary result that we have enrolled around 10,000 women, pregnant women. Out of 10,000, we have already 7,000 deliveries that have delivered as live birth. And screening has been done both at newborn unit and as well as at the maternal and child department, where these infants do come there for week 6. So we have screened. Our team have screened around 5,000 newborns and around 4,600 infants, and out of these, 2,000 have been positively screened for anomaly. Then they were further screened by our study clinicians, and out of those, 64 qualified for further evaluation. Out of 64, we have had 46 cases that have been reviewed by the local technician, and they have done echocardiography. Then we have a number of them that did not make it for further evaluation. 8 of them died before they were evaluated further by the local technician for echocardiography, and others have not shown up for further evaluation. So the suspected cases that were screened positive by the initial echocardiography were around 13 cases. Then thereafter, those 13, we did refer them again to be confirmed by the pediatric cardiologist. So out of those 13, 8 were confirmed to have a congenital heart defects, and PDA was the one that out of those, the PDA was 3 cases, then others were 1 cases each. And for now, we have 1 case that had been booked for surgery. So all these processes, again, it comes with the number of challenges. One of the major challenges that we did experience, especially when we were starting, was poor quality of infant pulse oximeters. Most of the pulse oximeters were somehow faulty, and at times it was giving faulty readings, and again, giving us a headache on frequent breakdown. Then we had a poor intake and implementation of screening procedures, especially from our team from the Ministry of Health. A number of them, I think they saw that this screening is like an extra work for them. So again, and others, they did not take that implementation correctly. So you find some cases had a false positive interpretation, and others had incomplete screening. Incomplete screening in the sense that you find a saturation has only been done maybe on the hand or only in the foot, but now the other limb has not been done. Then in this region, we have a shortage of technicians in this region. For us to perform that initial echo by a technician, we have to travel at around 150 kilometers to meet that one technician to perform this echo for us. And at times we may reach there and to find he has a lot of workload. Then it's a challenge. The challenge for normal babies, maybe outside under normal Ministry of Health care, maybe a challenge for them to be evaluated further. Then some cases that have been positively identified are not showing up maybe for further evaluation. And this is because some of the congenital anomalies are not that critical, and the community again is not that much sensitized congenital heart defects. So whenever you communicate with them and give them advice, maybe for further evaluation, they may not own it up at that time, but some of them you find they come much later when maybe the condition has worsened. That's when they will come back for further evaluation. Then in this end that we are, availability of pediatric cardiologists, we do not have a resident pediatric cardiologist in this region. The only one available usually comes once in a while, and it also a distance around 150 kilometers away to reach him. So for those reasons, you may find, suppose you have a critical case, it's hard to be intervened in quite early. Then cost of implementing this routine screening somehow prohibitive, especially outside the study settings. One of the reasons is the cost of the echo machine or the ultrasound machine. It's quite pricey. It's something that may not be easily maybe implemented by the maybe by the NOH team. Also the technician have not been empowered that much to do echo for pediatric care. So it's quite prohibitive and a challenge in the setting that we are. So all this, it's a learning process, and we are still learning. One of the lessons is that to have the importance of using or having a reliable pulse oximeter, an oximeter that can give an accurate readings for you to be informed maybe on the next line of management for these cases. Then our MOH team, basically they need to be sensitized and trained better on the correct use of these SpO2 measurements. Some you may find maybe the technique that they're using for doing this procedure, sometimes it's wrong. Then at times they find it's an extra work for them. But suppose maybe this screening for congenital heart defect is implemented in their normal program, then it will be a routine for them to do it. So it needs also a dedicated team and resource, also time for these cases, especially the technicians and the whole system as a whole. And also the availability of pediatric echocardiography for capacity building is needed. In this sense, the technicians, yes, they might be there, but they have not been empowered fully to perform pediatric echocardiography. Maybe it's an experience that someone may be having, maybe it's an experience maybe when he was in college, but from there, he has never performed an echo for this case. So that capacity building is needed at least to propel the further this screening of congenital heart defect. Then the program is still ongoing. We still have like a year to go, and we are still collecting more data on how best we can improve in this congenital heart defect screening. So more report maybe will be available in the next year. Thank you so much for listening. Sorry so much for that technical hit. It's one of the challenges that we do have in this resource setting.
Thank you very much, and thank you for persevering through despite the challenges, the technical challenges we're experiencing. And I like how you covered it by saying that it's because we're in low and middle income countries. So I think most of the attendees here will relate with the challenges we are facing. Thank you so much. That was quite a good presentation on the challenges and successes of screening for congenital heart defects in Kenya within a study setup. And I think it builds on what Baba spoke about level 1 within the model, focusing on screening within the community health setup, primary healthcare setting. And we would like to hear from you. If you have any questions to Ken, please feel free to put them in the chat. We have one more presentation before we embark on the Q&A section. So please hold on to your questions or type them in the chat box. And I can already see Professor Anita Carr is there with questions. Thanks, Anita. I can see you there. Stephanie and Ben Jones, thank you very much. So we will handle this as soon as we finish our last presentation. And speaking of our last presentation, we will now move straight down to South Africa and hear from Lizelle Jacobs, who's a senior research consultant at the Center for Infectious Disease Epidemiology and Research, that's CIDA, at the University of Cape Town in South Africa. Lizelle Jacobs is a senior research consultant, and she is part of the Ubomi Bunle in Cape Town. She's a medical officer in neonatology, and currently she provides support and training from the Global Birth Defects app. She has spent 15 years working at the Mowbray Maternity Hospital in Cape Town, where she provided community outreach to several clinics, including training of midwives and junior doctors. Lizelle was also a champion in collecting perinatal data for the PPIP, that is a perinatal problem identification program. And this formed part of the National Saving Babies report. Important to note that Lizelle is married and lives in Cape Town with her 2 boys, and her hobbies include photography and open water swimming. So Lizelle, over to you. Please welcome and feel free to share your experience within the POPSICLe study in South Africa and how a screening has helped. Go ahead, please.
Thank you, Caroline. Thank you for that introduction. And thank you to the team for allowing the opportunity for me to speak today. I'm going to share my screen, and let's hope the technology is in my favor. Okay. So thank you again. Our pulse oximetry journey started in 2015 at Mowbray Maternity Hospital, which is a secondary level hospital in Cape Town, South Africa. Dr. Annika van Niekerk, who we're lucky today is actually has joined us for the webinar, is a pediatric cardiologist, and she became passionate that with nearly 1,000 deliveries per month at Mowbray, we were not diagnosing about 2 to 3 critical congenital heart diseases. And after one specific case went home undiagnosed, only to return in extremis after a collapse at home, we embarked on a little pilot study at Mowbray Maternity Hospital. It was an implementation feasibility study on pre-discharge pulse oximetry for critical congenital heart defects in newborns. It was quite a mouthful, so we called it the POPSICLe study. Anne de Valgranelli came to visit, and she basically suggested we use her protocol of hand and foot SATs measurements, with SATs more than 95% seen as a pass and more than 3% limb difference seen as abnormal. The study was published in the SAMJ in 2016. And I'd like to thank Dr. van Niekerk, who kindly gave me some of her talk to share with you today. This was our screening protocol that we used. And as I said, we screened well-looking term or near-term infants at or after 6 hours of life. We followed a 2-limb protocol similar to most international protocols at the time. This was a small pilot study done in only one of our 3 postnatal wards at Mowbray over a 4-month period. And we only managed to offer 45% of mom-baby dads from that ward pulse oximetry screening. In that time, we did, however, manage to screen 1,001 babies, of which 999 passed and only 2 failed the screen. 1 being diagnosed with the transposition of the great arteries, and this baby was swiftly admitted to our neonatal ICU, started on prostaglandin, and referred to Red Cross in a stable condition. She had a successful arterial switch the following day with no complications. The other had neonatal sepsis and required 3 days of nasal CPAP and 7 days of antibiotics. 1 patient with a coarctation was screened and had passed and presented at Red Cross emergency room at 6.5 weeks of age. This was our 1 false negative case. So in this pilot, the sensitivity was 50%, the specificity 99.9%, with percentage correct of 99.8%. Despite not nursing staff shortages during our study period, which is a reality in most South African public hospitals, our nursing staff viewed pulse oximetry favorably and were eager to see this implemented routinely. 75% felt it would be possible to incorporate it into their everyday routine, as long as they had a full ward staff complement. Our study also confirmed parental acceptance. Most parents felt routine screening should be standard practice. The implementation feasibility means a high success rate of screening along with sufficiently low barriers and resource drain. The Mowbray staffing resource challenges during our study period resulted in only 45% of our postnatal ward discharges being offered pulse oximetry screening. But our study demonstrated acceptance and buy-in from nursing staff and parents and a good sensitivity and high specificity. And it also confirmed that pulse oximetry screening does not significantly increase the pediatric cardiology service workload. We postulated that routine screening, not part of our study, would translate to less paperwork, less nursing time, and a higher percentage screened. In addition, the ongoing controversy over whether both pre- and post-ductal screening is significantly superior to a single post-ductal screen may mean that a single foot saturation screen right before discharge is the more practical solution, especially in resource-limited settings. So this is the simplified pulse oximetry protocol we've been using since 2016 at Mowbray Maternity Hospital. Seemingly well-term or near-term babies are screened from near 6 hours of life, using only 1 foot SATs. SATs of more than 95% is a pass, less than 90% is an outright fail, which means that the baby needs assessment. And then the middle SATs of 90 to 94% needs 2 repeat screens. A rough recent audit showed we were screening nearly 90% of all our well postnatal ward babies now. And we had a refresher in 2019, a refresher course workshop, and a fun midwife-focused pulse oximetry workshop on the 3rd of December. And this showed that most of our Western Cape state facilities and most of our Metro West midwife obstetric units, which we call MOUs, are screening where possible. This was the starting slide at that event, which is still applicable today. We were proposing pulse oximetry becomes part of a basic newborn care. We found 5 specific obstacles in our screening in South Africa. Firstly, the overloading of our already overloaded cardiology system in South Africa. But this has not actually been our experience in the Western Cape. In fact, our cardiology department welcomed and supported pulse oximetry screening, because since an early diagnosis actually paid off in the long run, the late critical congenital heart diseases pickups were already showing complications and had much more complex and often caused the backfall in surgical lists. South Africa, as with other countries spoken today, also has limited pediatric cardiologists, and it's approximately less than 40 at the moment. The second obstacle we faced was the word screening program. And this is met with lots of prerequisite red tape, politics, and even if it might become law, as in the United States, fraught with medico-legal implications if you miss a baby. In this 2015 study, we only screened 45%. And we argued that this was because it was a study, it entailed consent taking, paperwork, etc. But ultimately, staff shortages was the major issue, which is like I said before, commonplace in our South African state service. Experience has also showed us that most babies who fail pulse oximetry actually have other signs associated with an illness. And these could be group B strep, which is often clinically only presenting at more than 6 hours of life. In many of our under 5 lower respiratory tract infection studies, it has shown, despite several IMCI or lists of symptoms that staff look at, such as fever, tachycardia, etc., SATs of less than 90% is by far the most accurate sign showing risk. And this would then show that the baby would need admission. So the answer to this would be, in our opinion, it must be part of the basic newborn care, and pulse oximetry should be promoted as the 5th vital sign. Our vision is that hopefully all community healthcare workers will one day be equipped with a SATS monitor in their pocket. Sorry. Our obstacle number 3, in our view, was our biggest obstacle. Like I said, in our Mowbray POPSICLe study, we only had 45% screening uptake, and ultimately the staff shortages and staff time was the major issue. The recent rough audit showed we now are screening nearer to 90%, and this is with a very well-oiled Mowbray education department, training of all the new shifts, and having pulse oximetry champions. Other South African studies, such as Dr. Govinder's very guarded study from KZN, which is KwaZulu-Natal in South Africa, showed also more, and as well as more positive MMeds from Dr. Michael Platten at Baragwanath, and Dr. Sifani's study also confirmed that their major obstacle is definitely nursing staff workload and time. So our answer to this was simplify the protocol to 1 foot SATs only. And if it's more than 95%, then it is a pass, and making it pass of basic newborn care. So there were no long explanations needed. All babies were screened. Which algorithm to use and whether it's 1 foot versus 2 limbs approach is still very much a hot topic. Obstacle number 4. Last year, we advocated that pulse oximeters, probes, and nursing training is not the big issue, since pulse oximeters are part of the essential list of equipment of all birthing centers, and nursing staff should know how to use them properly. The probes marketed for single use can actually safely be reused many times. Since then, we have been made aware that many of our midwife obstetric units do not even have a dedicated neonatal resuscitation pulse oximeter and probe, and they are actually functioning with 1 to 2 old pulse oximeters on the Dynamap machines shared between the postnatal maternal care and the neonatal resus room. And often they only have the adult probe. Our 5th obstacle was education and training. Large hands-on training was being hampered by COVID initially, but by simplifying the protocol and having many demonstrational posters and videos in English, Afrikaans, and isiXhosa, as well as all facility education department and community lead buy-in, getting the training done was showing to be quite possible. We were also getting the message across to parents with parent pamphlets, posters, and videos, which will also enhance the uptake. So to recap the general list of barriers and what we thought, firstly, pulse oximeters, probes, and nursing training is now not actually such a big issue anymore, since pulse oximeters are now part of the essential list of equipment of all birthing centers, and nursing staff need to know how to use them properly. The probes are marketed for single use, but by using basic hygiene principles and common sense, these probes can actually be reused many times. The burden on cardiology services was very small if you followed a 3-screen protocol, and the cardiology service actually welcomed timeous diagnosis rather than a high risk and more costly late diagnosis. Nursing time was the real issue, which we at our facilities often understaffed and nurses overworked. So this required extra 1 to 5 minute thing was not easily welcomed. We found that incorporating the screen as part of routine pre-discharge assessment or routine daily care and only using the 1-foot SATs made it doable. Not using the limb difference makes it much simpler. False positives are acceptably low when doing the screen near 6 hours of age, when many of our well babies are discharged. When we make decisions about the optimum time to carry out pulse oximetry, we need to balance the risk of false positives against the likelihood of timeliest diagnosis of true hypoxic pathologies. For newborn pulse oximetry, a true false positive should be redefined as those cases where there is no other pathology and a normal heart is just undergoing a prolonged phase of transition. These cases may require a few more hours observation with their mothers. Lastly, we will unfortunately always have some false negatives. This is, after all, only a screening test, probably mostly left heart obstructive lesions. Technology may improve and help reduce this number, but since most false negatives are actually non-hypoxemic patients early in life, a clinical review 2 days after discharge, which is practice for us, ideally with another SATs measurement would be ideal. In 2020, we asked our Metro West midwife obstetric unit, so this is the primary care unit, feedback of how it was going and what their opinion was. We wanted to know what coverage they were reaching, what issues they experienced. And as you can see, most of them were reaching more than 90%. They found the screening to be easy, but the main issue was equipment, often only having adult probes and the pulse oximeter only being available at the resus station. This was Samantha Govinder's 2016 study at Addington Hospital in KwaZulu-Natal, and that also showed several barriers, including staffing and infrastructure. This was Dr. Michael Plassen's study of pulse oximetry accuracy at altitude and in detecting critical congenital heart disease. And it showed in his study that altitude didn't affect the accuracy. In 2019, on the 3rd of December, when we held the pulse oximetry workshop at Falkenberg, the feedback we received was that, and if we looked at the amount of deliveries that were happening, we worked out that we needed 2 functional pulse oximeters with neonatal probes per 3,000 deliveries. So our metro needed a minimum of 35 pulse oximeters to have a good rollout. This unfortunately wasn't possible. So with the bare minimum of 15, we had to make a plan, which is what was being used at the time. The other question of which algorithm. So similar protocols to ours were being currently used in New Zealand, parts of Australia, Ireland, Poland, Germany, and Switzerland. The Tangarithium meta-analysis in the Cochrane review did not show to be inferior, although some argue we may pick up a few more critical congenital heart diseases using the 2-limb strategy. We will always miss a few, especially the left heart obstructive lesions. That's why hopefully the routine 2-day after discharge checkup is so important. New computer and phone apps can help guide the user in the 2-limb result, which may be useful in high-tech, low-volume centers, but this is still many years away for most of South Africa. Gains are being made in the global spread of critical congenital heart disease screening. North America and Europe have made the greatest activity in pulse oximetry screening. Impressive activity in South and Central America is occurring, with more countries having national recommendations. Implementation is underway in Australia. Asia has made progress in selected regions. So Africa is further behind in implementation, as is newborn screening and access to specialized medical intervention in general. As far as I'm aware, 1-foot SATs pulse oximetry are currently successfully being used in New Zealand, large parts of Australia, Ireland, Poland, Germany, and Switzerland. So where are we now in South Africa? All our babies have pre-discharge pulse oximetry screen. This little icon of the POPSICLe is what we put in each of our babies' Road to Health cards, so that everybody knows what their discharge pulse oximeter screening was. We identify about 1 to 2 congenital heart diseases per year, but other conditions that we also pick up is persistent pulmonary hypertension and sepsis. So we've seen it to be very helpful. Now, I'd just like to show you a little 5-minute YouTube clip that we made about our study. And we'd like to thank the UCT Medical Student Program called Stepping Stone, who did this for us.
Congenital heart disease is actually the commonest birth defect, occurring in about 1 in 100 babies. But it varies from mild to severe. Very severe or critical congenital heart disease is where the heart chambers or where the heart vessels have not developed normally in utero. And about 3 in 1,000 babies will be born with such a critical congenital heart lesion. As a practicing pediatric cardiologist, it's always a big concern. And as a mother, I can understand how very hard it must be when you have what looks like a seemingly normal baby, and then being told that this baby has severe congenital heart or even critical congenital heart disease, and how that affects not only the baby, but the whole family for forever. Pulse oximetry screening is a newborn screening test where we would have a small, simple sensor for the hand and 1 foot, and it reads the oxygen level in baby's bloodstream. One wonderful success story is a young girl, POPSICLe Yambani.
Because they did the.
And she was actually in the discharge room, right, ready to leave.
She saw the signs because she thought it was just the wind that the baby had all the time.
The pulse ox screening test discovered she was actually fairly below the normal oxygen level, and soon realized something's wrong and discovered her vessels had not formed correctly.
I was shocked and confused because nothing did go wrong when I was pregnant. I was scared, but Dr. She gave me hope. I'm thankful that they did the test before she got home.
If we have a diagnosis, we feel so much better when we know what it is. It's much worse for babies that pass away or are never diagnosed, and their parents don't realize it was actually a heart condition that caused their demise.
It's worth knowing everything about your baby. I also decided to stay at home and look after her after the operation to see how she is coping and everything. But she's doing fine.
She's never needed hospital admission again. She is now nearly a year and a half and a beautiful big girl. Since I've seen a few babies with critical congenital heart lesions at Mowbray, who unfortunately went home before it was picked up and then returned in extremis, shocked and near death, I really felt we should start a screening program, since it's done internationally, seeing if we can pick this up before it leads to all those problems. POPSICLe comes from the words pulse oximetry pre-discharge screening in newborns for critical congenital heart lesions. It spoke to some of the desperate needs around congenital heart disease, and for us it just seemed a very easy way to identify these children.
It was a challenge initially
because we had not sufficient staff members at that time. And absenteeism obviously played a big role.
It makes me feel good because we saved a life. We now could have peace of mind, and we would like to implement it now as routine care in our wards.
I'm actually very excited about POPSICLe so that, as I said, we can make a difference in those children's lives.
It's all about caring. Besides the fact that we are giving professional care, we also need to care for people.
I love you, my baby. Love you so much.
Thank you to everybody who listened to my presentation this afternoon.
And thank you very much, Lizelle. That was really good. And what a nice point to end on with that video. And just a reminder that the video is available. There's a link to the video in the chat, so you can watch it again and also share with your networks. That was really good. Thank you so much, Lizelle. So many interesting points I picked up. One is pre-discharge screening of all children with pulse oximetry is something that we can all aspire to, especially in our setup. Really good to see that. And you shared lots of information, lots of scientific research that backs this up. And I was quite amazed to hear the any foot, 1 foot mode of screening with pulse oximetry. I'm sure Ken and others would have something to say about that, compare notes and contrast. And the fact that we do not call it a screening program, but we incorporate screening for congenital heart defects within the newborn care program. Otherwise, if you tell people that you're introducing something new, they would feel that this is additional work and resources and all that. So really quite interesting. So thank you very much, Lizelle, and thank you very much, everyone, for getting to this point of our webinar. We are now at the Q&A section, and it is your time to shine as attendees. And please, I will request, could we have hands raised if you want to ask your question out loud? And otherwise, I'll also move to the Q&A section and see the questions that were posted there and what answers might have been provided for the same. Anyone who wants to be brave and go fast? Maybe someone from West Africa, if we have anyone. No pressure, just if you have a question, feel free to raise your hand as I look into the chat box. Okay, I can see, I'm just quickly looking at the chat box as I wait for hands to come up, but I can see Professor Anita Ka already asked a question. Thank you, Dr. Hassan, for the excellent presentation. My question is, if pulse oximeters are not available, is it possible to train community health workers to suspect a congenital heart disease so that the baby can be referred for further investigation? And maybe, Baba, you can say something briefly on that instead of me reading out what you said, and then we can move to the next.
Yeah, first of all, thank you very much for that question, Dr. Carr. Really an honor to have you on the webinar. And we have learned quite a bit from her and from her birth defect screening program that we are trying to apply even in Pakistan. So what is interesting is that, I think pulse oximeter, critical congenital heart disease is predominantly what we're trying to pick. But the work that we have done using our AI model is actually targeting at-risk neonate. So the at-risk neonate, by definition in our study, is it's basically, it's a community. It was done in a rural community, this whole work. But the at-risk neonate are kids who have critical congenital heart disease, kids who have severe pneumonia, kids who had severe sepsis, or kids who required hospitalization or died within the first 1 month of life. So, and we showed an 85% sensitivity using our sequential ML model. But without pulse oximeter, it's difficult to pick the critical congenital heart disease, but one can teach, kind of some telltale signs. And in our sequential ML model, we actually stressed quite a bit on the WHO signs and symptoms, which gives, it's more specific for neonatal sepsis, but it can also give some tips that the kid is not, healthy enough and there's something going on, fast breathing, and then also helping them, learn how to examine the femoral pulse. So it's not easy. It's even for a trained physician, it's not easy to do that. There are some places that are actually teaching lady health workers to auscultate the heart, and then there are some solutions that we are working on using digital stethoscope and AI algorithms to pick abnormal heart sounds. But without a pulse oximeter, at least my experience has been, it's very difficult to pick critical congenital heart disease. Teaching some of these signs and symptoms and physical exams to the lady health worker is definitely a possibility.
Thank you very much, Baba. Well put. Yes, Anita is our champion in community screening for congenital heart defects. She spoke about this in our last webinar. So yes, I agree with you. We learn a lot from their experiences in India. Now, there's an interesting question here. Anita again asked Ken, why was there such a major difference in the screening by nurses and the study team? The numbers were quite different when the Ministry of Health nurses were doing the screening compared to the trained study team members, although we also actually trained the Ministry of Health study members. And I think maybe, Lizelle, you can jump onto this, because in your presentation, you mentioned something about 50% sensitivity and 99.9% specificity. So we better pick them up. We better pick everything rather than lose something, so to speak. Maybe you can speak more to that. And of course, Ken mentioned something about a number of factors, including technique and pulse oximetry and false readings. Lizelle, maybe shed some light on sensitivity and specificity with pulse oximetry.
Yes, so like I said, that was our study originally in 2016 that we published, and it was only 45% of our postnatal ward that we actually managed to screen at that time. So it wasn't, you know, number-wise, it wasn't great. And I think because it was a study, it took time and staff workload and all of that. Since recently, we're getting at about 90%, if not more, of all our babies are being screened now. So I definitely think our sensitivity and our specificity has improved greatly since those days. We still, if we look about, we're picking up about 2 to 3 per 1,000 live births. And for us, that in our setting, which is quite a big amount of babies being born in that setting, it was still manageable for us, if that answers your question.
Yeah, thank you very much.
But I do think with training and also the training of how to do it. So I was actually part of the training that went to all those primary midwife clinics and actually trained the nursing staff on how to read it, how to put it on, and I think since we've implemented the training, our sensitivity and things have also improved greatly.
Okay, thank you very much, Lizelle. Yes, Baba, go ahead.
Yeah, just wanted to, again, so it's an interesting thing because pulse oximeter and even the WHO signs and symptoms are highly specific tools. So if you use what we call a sequential way of, like, that's what physicians even do. We sequentially diagnose somebody. We just don't go and we won't walk into a room and say somebody will have this patient has critical congenital heart disease. There is a sequence to it. We get a history, we do our physical exam, and then we put all of that together. So for example, in our work, what we did was that if this highly specific tool was positive, then that patient was referred for further evaluation. But if that was negative, we went on to the next specific tool. If that was negative, then we went on to our machine learning tool. And if what the machine learning tool did, it was basically clinical history that went into that model. And by that, the sensitivity improved, so the specificity dropped to 75%. But since the 2 highly specific tests were negative, you could easily monitor these patients at home and not refer them to the next facility. So your specific, those are false positive, but they are not by a very highly specific tool. So one can really think on those different models and sequentially apply these different tools to improve the sensitivity, because that's where the whole challenge becomes with pulse oximeter, is that once you go into the community where you don't have that kind of a highly specialized model, outside the hospital in the community, the sensitivity really drops. And that's a lot of that work from even Anita Saxena's group from India has shown some of that.
Yeah, thank you so much, Baba. And please feel free to raise your hands. I'm just highlighting some of the questions in the Q&A box but as soon as anyone raises their hand, I'll freely hand over to you. But Stephanie Daliko asked a very good question here about sharing experiences with remote support for congenital heart defect diagnosis and management. For example, using real-time video links, such that if you're in a resource-poor setting, at least you can get some advice and direction and way forward. Baba, I'll hand over again to you. I think this was good what you put in the chat, in the Q&A.
So we have actually published some of this work, and we have, and I know there is some, there are issues around HIPAA and all of this, but one has to again balance a lot of that, the benefit and the risk of doing that. So we use a lot of WhatsApp, and we use a lot of WhatsApp remote counseling and remote consultation, and that has worked really well for us for many patients who we have preoperatively managed. Some of them who are getting their nutritional rehabilitation, for example, in the community, preoperatively managed with the local pediatricians or even physicians or even community health workers, and even NGOs which are working deep in the communities. We have kind of trained them and worked with them. And then post-operatively, even managing some of these patients within their communities. Some of these patients are living, 600 kilometers away. For them to come for just a simple superficial skin infection from the wound, it becomes pretty cumbersome and expensive. But we've also now started to partner with Sandra Matos from Brazil, who has done a tremendous amount of work in using telemedicine and low-cost telemedicine to provide consultation in remote parts of Brazil. And we're trying to replicate some of her work. But it has a huge role, especially in that 5-level system that we have developed. That's where the level 4 and level 5 are really connected to the community. And the community hospital or community center is not feeling in isolation, that they're just kind of screening and diagnosing, and they don't have any other place to send them. And then all of these 5 places are connected in that manner in improving the quality at each level. And these kind of remote solutions or remote telemedicine or consultation solutions can be extremely helpful. And we have found it very helpful.
Thank you very much, Baba. And you mentioned level 4 and level 5, and I know Bistra is here with us from ChildLink. And I think I must give an opportunity to share on what ChildLink is doing to strengthen level 4 and 5 in terms of capacity building and of our healthcare providers here in the low and middle income countries. But before I move to Bistra, I feel like Judith is asking a few very important questions in the Q&A section, and also mentioning that they've begun a fetal heart screening in Uganda. Dr. Judith, are you online, please, Namuyonga? If you could please unmute yourself and tell us about the heart screening program you have fetal heart screening program you have in Uganda, as well as the question you had on pulmonary hypertension. Please go ahead, Dr. Judith.
Oh, thank you so much. Let me just park at the roadside. I had decided to move.
Yes, please be safe. Yeah, go ahead.
Yes, so my name is Judith. I'm a pediatric cardiologist. I work with the Uganda Heart Institute. So my question was about, I think someone who gave a talk on the screening with oximetry at the different levels, and they identified congenital heart disease. I did not see anything stating, say, pulmonary hypertension. We know it's not congenital heart disease, but it would be interesting to know how many of those babies had pulmonary hypertension. Obviously, some of them have hypoxia and low oxygen saturation. So I'm sure that they should have appeared, but how many of those were identified on echo by the pediatric cardiologist? Number 2, I mentioned that we started a fetal heart screening in Uganda. 2 of us have been able to train elsewhere. I did advanced echocardiography, and a colleague of mine did fetal cardiology. In my training, I also rotated at the Women's Hospital where we did fetal echo screening. So that skill has been carried back home. And we started 2021 October. So this is running at the Heart Institute. Of course, it's not very common, and it's not a routine thing that our obstetricians or gynecologists are able to identify these at-risk mothers. So one of the things we are really looking out for is increasing health education, the indications of a fetal echo, who needs a fetal echo, previous pregnancies that have had complex congenital heart disease, mothers that have had, say, congenital heart disease, a history of aortic valve stenosis, we know that that can run through families and can go through. So it's a big task. I know that we are still not doing so well with managing all our congenital heart diseases in the country, especially operating them. But I believe there are families that we can't deny the opportunity of having prenatal screening than getting surprises at birth, and this country doesn't have prostatin. Maybe the Kenyans have prostatin, the prostaglandins we do not have in Uganda. So what we are using at the moment are dinoproston, which we know is used during pregnancy. So this is what the concoction we are doing to give fetuses that we say diagnosed with critical coarctation, or fetuses that have transposition of the great arteries before we think of doing a cath. My hospital does catheterization, so we are able to have atrial balloon septostomies. But you know, all this is possible if you have planned early and you've diagnosed this early in utero. So you plan the delivery and plan. So it's still in its early phases, but I'm very excited about it. I think it will improve our care as a country. Thank you very much. It's just a comment. Thank you so much.
Yeah, thank you so much, Judith. It's always nice to hear what we are doing. The reason we have this network is to share experiences. So really good to hear what is happening in Uganda. Thank you. You asked a question. Maybe Ken, you can answer this. Did we have any children who had features of pulmonary hypertension, perhaps, or Lizelle, in case you had seen this? Ken, please feel free to go ahead first.
Yeah, thank you, Dr. Carol. Thank you, Dr. Judy. I think from our end, we had one case that whom we flagged at around 6 months had dilated pulmonary hypertension and dilated cardiomyopathy.
Okay.
I think I meant persistent pulmonary hypertension of the newborn, which is a big killer, especially if you don't diagnose it early and if you do not manage the newborns quite early. It can be a confusing factor in the immediate newborn period.
Okay, yes, Baba, go ahead.
Yeah, so in our study, we definitely picked them. You are right, absolutely. So we had, I don't exactly know how many numbers, but this was done on 1,000 patients that we had done this study on. It was a pilot, and we definitely picked persistent pulmonary hypertension with a duct that was right to left. And those were the patients that we very closely monitored, because as you have pointed out very correctly, that these patients can get really sick if especially those with a right to left duct and severe PPHN, these patients can get sick.
Yeah, okay. Go ahead, Lizelle, please. Yep.
Yes, I'd also just like to say that we definitely had some that failed pulse oximetry who were persistent pulmonary hypertensions. And you know, I think still at this point, most of our failed ones at about 6 hours are sepsis and PPHN. And they can be very sick.
Yeah, thank you. Thank you very much. Now, anyone who could speak to that, what about capacity building and training okay, first of all, equipping even our health facilities to be able to take care of these cases that we are detecting. As Baba said, access without quality will cause harm. So even if you screen these children and you diagnose them with these conditions and you have nothing that you're doing for them, is it even ethical? That's one of the questions we can ask. And what is being done within the LMICs to strengthen the capacity? Are there any examples that anyone could share that's happening in their country?
No, absolutely. I think the main thing is definitely this decent amount of work that has been done, even in Uganda and many other places, about using echo and lady health workers actually using handheld echoes to diagnose, again, rheumatic heart disease. It's not for congenital heart disease, but there's quite a bit of kind of work. So some of the things that we have done is that we have trained some of our local, and this is even Sandra's work in Brazil, that she has trained some of our local pediatricians to do echoes and then does remote consultation on the echoes that were done by them. And she's shown significant amount of detection using that. I think the important point is, again, the responsibility is those level 4 and level 5s. We cannot leave the communities in isolation. So if we are putting, for example, a handheld echo screening program that is in the community, which definitely in the 21st century, we should start thinking about this, that we should then build a quality metric around it, diagnostic accuracies, diagnostic errors. These are very well-defined metrics that the level 4 and level 5 can use to improve, give feedback and improve those centers in their ability to diagnose properly. And it also improves human engagement, because when the end care provider is seeing improvement in their own skills and positive critical feedback coming back, which is objective, it really drives improvement. And that's some of the experience that we have had with some of our remote programs that we are putting in place.
Yes, and you mentioned Uganda, and I saw Judith's hand immediately went up. Judith, please go ahead, feel free.
Okay, so thank you again for letting me say something about Uganda. I think we started with, I was part of a team that was doing the telemedicine echo training. We had training of nurses in the northern part of Uganda that would do echocardiograms, whether they were looking for rheumatic heart disease or congenital heart disease. They did this, but we had cardiologists back at the Heart Institute that would read the echoes sent online. So we're able to access images and review those, and especially if the nurse did a study and noticed that it was abnormal and maybe the patient was so sick. Of course, it gets back to clinical skills, being able to take a history, do the basic clinical exam, and which any nurse could do that once they are trained. Pulse oximetry is one of the most important things that we could use. So these nurses would alert us and say, there's a patient I have seen in the northern part of the country who is quite sick and has this and this. Could you please find time and look at the images? So we did that. And in those images, we're able to study the echo and then treat online. So that is one thing that could be done. That even when you're training the low-level health workers at, say, level 1 or 2 or 3, whatever you would want to call it, you'd need to support them with senior clinicians or cardiologists that are able to interpret whatever results they've picked on the handheld echo machines. So that's what we did in Uganda. And I think that is very, very important, that they need support. You need someone who'll say, this picture is not very good, or this is correct. And if it's not, if any echo image doesn't look normal, different from the usual, congenital heart disease may be a bit difficult to diagnose. But what we've said is that if anything appears abnormal from the usual, then it's congenital heart disease until it's stated otherwise. Yeah, so if someone is used to looking at mitral valve regurgitation and then they see this weird structure on the heart, then it's most likely congenital heart disease. And then that's a reason for referral to the next health unit. Thank you.
Thank you very much, Judith. And thank you everyone for persevering to this point. We are slowly winding up. Any questions? Please feel free to raise your hand. That's the last round for questions. I'll just highlight the last one in the Q&A box where Stephanie asked, are there any specific pediatric pulse oximeters you'd recommend? Are there any oximeters that prevent reading before the required time? Because I think Kennedy highlighted this, that those are some of the challenges we've been having with the Ministry of Health staff. They do not wait the full 1 or 2 minutes before they take the reading. And Lizelle, yeah, you did mention something. Maybe perhaps you could just summarize it about funding and the make of the pulse oximeters.
Yeah, it's just like I said, it all depends on availability, what funding you get approved. And so it's difficult to say exactly what will work best for you. But I think the most important thing is actually training how to read it properly, getting a good trace, baby being nice and calm, ideally maybe even breastfeeding while it's happening. And I think that's the more important, not the actual monitor itself, but how you do it. Thanks.
Thank you so much, Lizelle. Thank you very much, Baba, Lizelle, Kennedy. I know Baba is on vacation in the UK. He took time off his vacation to present here. We really appreciate that. And I also appreciate, I appreciate all our attendees today. Thank you so much for being an active audience. And I hope we have benefited from today's presentation. So we've received many comments and questions, and so we'll gather all of this together and we'll ask our panel to respond this in writing. The recording of this session along with additional materials will be shared. The link to where you'll be able to find this will be posted in the chat now. Thank you very much to the panelists and to you all for your participation. We will now close this session. Okay, bye.